Good evening, everyone. I'm Saranjeev Rangaraj. I'm a PhD scholar from the Department of Biochemistry, University of Hyderabad, and also I'm a PMRF scholar. To fulfill my teaching assistantship, I've associated with this NPTL, and this is week 8, and we have been associated with the course called Overview and Integration of Cellular Metabolism. And so far, we have seen lipid metabolism and then the carbohydrate metabolism. Last week, we have started with how protein metabolism functions in the body, and we have started with the protein digestion and then the absorption and certain amino acid metabolism that we have seen. And today, we are going to see recap on the week 8 concepts and then some practice questions, and finally, we will see the doubt clearing session. We know that there are 20 amino acids like that we usually talk in terms of the protein metabolism. In that, certain amino acids are classified as essential, which cannot be synthesized in the body, can be taken only from the through diet. And second one is the conditionally non-essential. It depends on the availability or the requirement of the body. Certain amino acids will become conditionally non-essential, and non-essential amino acids are also there, which can be synthesized by our body itself. Today we will start with phenylalanine, tyrosine, and then the tryptophan metabolism. We'll see how they are synthesized in the body, how they are catabolized. Then finally, we are going to see if there is any kind of issue or the problem in the pathway related to these amino acids, how it leads to the disorders that we are going to see. So one such amino acid that we talk, phenylalanine, which is an aromatic amino acid and an essential amino acid itself, and it acts as both glucogenic and then the ketogenic. We have seen in the last week what are glucogenic. Glucogenic amino acids are the amino acid which will produce the intermediate precursors of TCA cycle or glycolysis pathway to produce the glucose as a final molecule through gluconeogenesis. And there are certain molecules will produce the acetyl CoA and acts as a ketogenic amino acid because that forms the ketoacids in the final as a final product. And this phenylalanine is converted to the tyrosine. That's why we will see it as a tyrosine phenylalanine pathway as a coupled pathway in the upcoming slides. And whenever body requires the phenylalanine, it can be synthesized by synthesized from tyrosine. So that's why it is referred to as pairing action of tyrosine on phenylalanine. And this is the phenylalanine structure if you see, and any amino acid will consist of one amino group and then one carboxylic acid group, and one R group will be there. The R group here is one benzene ring with CH2 molecule. And predominant of this phenylalanine metabolism occurs through the tyrosine because the very next step in the phenylalanine metabolism is tyrosine. And tyrosine is incorporated into the proteins and is involved in the synthesis of the variety of biologically important compounds. For example, epinephrine, norepinephrine, dopamine, thyroid hormones, and then the pigment melanin. So we are going to see one by one how these things are synthesized in the body and how they are going to be catabolized in the body itself. And this is the overall pathway of the phenylalanine metabolism. We will see it in the upcoming slides in the tyrosine metabolism, how the each steps works very well. In this slide, in the upcoming 5 slides, we will see how this phenylalanine is converted to tyrosine by the action of phenylalanine hydroxylase. And then if it is having any kind of disturbance in the phenylalanine hydroxylase synthesis, then that leads to phenylalanine ketonuria. So that we are going to see. The enzyme responsible for the conversion of phenylalanine to tyrosine is phenylalanine hydroxylase. And this hydroxylates the para portion by one atom of oxygen to produce tyrosine. The other atom is reduced to water. And this reaction usually is irreversible and requires a specific coenzyme called biopterin. So this is the overall reaction carried out by the biopterin. The active form of the biopterin is having the 5, 6, 7, 8 tetrabiopterin. Whenever it forms the H2O molecule, this tetrahydrobiopterin will be converted into 7, 8 dihydrobiopterin, which is a quinonoid form. Then again, in the by the presence of the dihydrobiopterin reductase, one molecule of NADH plus NADH plus H plus will be used, and again it will be formed as a active form of tetrahydrobiopterin. And here the phenylalanine will be converted to tyrosine by the addition of one oxygen molecule in the para position, and whatever the hydrogen is there in the para position, that will be directly shifted to carbon 4 to carbon 3. So this is called as NIH shift because this feature is discovered at the National Institute of Health. That's why it's called as NIH shift. So the active form of the biopterin is tetrahydrobiopterin that we have already discussed. So tetrahydrobiopterin is oxidized to dihydrobiopterin. Oxidase means the removal of the oxygen is called as the oxidase. And tetrahydrobiopterin is then regenerated by NADPH dependent reaction called dihydrobiopterin reductase. And usually this phenylalanine hydroxylase is present in the liver. And this is the overall reaction. Whenever the 7, 8 dihydrobiopterin is there in the body, in the presence of dihydrofolate reductase, the cofactor here is NADPH plus H plus, which will be converted as NADP plus. And it will be converted to 5, 6, 7, 8 tetrahydrobiopterin, which is otherwise called as BH4. This in the presence of phenylalanine as well as the tetrahydrobiopterin, phenylalanine hydroxylase will convert phenylalanine into tyrosine. And again, this uh, tetrahydrobiopterin, by the oxidation of removing the two hydrogen atoms, here it will form petrin 4A carbonylamine, and again one molecule of H2O will be removed. Then again it will form the quinonoid form called 7, 8 dihydrobiopterin. And this 7, 8 dihydrobiopterin, again by the action of dihydrobiopterin reductase, it will form the active form of biopterin. So this is the cyclic form. Again and again it will happen to produce tyrosine. So in this step, any kind of disturbance happens or any kind of blockage is there in the pathway where the phenylalanine is converted to the tyrosine. There the issue comes the disease called phenylketonuria. So this is usually the most common disease of the amino acid metabolism, that due to the deficiency of the enzyme called phenylalanine hydroxylase enzyme, and a single mutant recessive allele of phenylalanine hydroxylase gene, that is location is long arm of chromosome 12 and locus 22. So this is really really important for any kind of exam. You can go back and then read. And this is autosomal recessive inheritance. We will see what is autosomal recessive inheritance in the body, and this results in the hyperphenylalanemia, or else sometimes it will be excreted in the urine itself. So both the cases it happens. So the phenylketonuria, mostly it happens in the case of the phenylalanine hydroxylase is not there in the system. Due to that, the phenylalanine is accumulated in the body and it cannot be converted to tyrosine, and then the downstream products will not be formed in this case. So how this happens? Not only in the phenylalanine hydroxylase thing. Suppose the cofactors responsible for the phenylalanine hydroxylase action. For example, here we know that the tetrahydrobiopterin, this uh, cofactor is not available or the coenzyme is not available, then that also leads to the phenylalanine accumulation, because this cofactor or the coenzyme is really really important for the phenylalanine hydroxylase function. So then finally the phenylalanine is accumulated. And other enzymes like this petrin 4A carbonylamine dehydratase. So these enzymes also, if it is not there, then again the phenylketonuria will take place. So there are two set of phenylketonuria that we can classify. One is classic phenylketonuria, that is due to the deficiency of the phenylalanine hydroxylase maximum, and then second one is the atypical hyperphenylalanemia, that is due to the deficiency of that tetrabiopterin, or the caused by the deficiency of the enzymes, that is dihydropyridine reductase or dihydrobiopterin synthetase or carbonylamine dehydratase. So these things are responsible for atypical hyperphenylalanemia. So the next synthesis of from the phenylalanine, not exactly from the phenylalanine, it's synthesis from the tyrosine. So the tyrosine converted into dopa and then dopaquinone and then leucodopaquinone and then the dopachrome and then finally the melanin will be formed. And this melanin will not be there if the phenylalanine is not metabolized properly. So this leads to the no or less melanin in the body and then light skin in the phenylketonuria patients. And next one is this phenylalanine is also important for the production of the catecholamines. And then this phenylalanine high levels will go into the brain and then that will not allow the any other uh, uh, aromatic amino acids to enter such as the tryptophan. So that leads to the reduced levels of serotonin and that leads to the mental retardation. And finally, there is one receptor called ALN80 that is used by this large neutral amino acids such as the phenylalanine or tryptophan or tyrosine. Whenever the phenylalanine levels are so high in the body, this large neutral amino acids compete for the transport across the blood-brain barrier, where the large neutral amino acid transporter that is called LN81. And if any phenylalanine exists, so this goes and occupies this LN80, so that reduces the other large neutral amino acids in the brain. So that leads necessary for the protein in the neurotransmitter synthesis, such as the tryptophan in this case. And phenylalanine buildup hinders the development of the brain, causing the intellectual disability. And if any kind of high levels of phenylalanine there in the body, that can be converted into two cases. One thing is in the presence of the PLP, that is aminotransferase reaction. This can be converted into the phenylpyruvate, where the alanine will be formed as a byproduct. The second thing is this phenylpyruvate, by the removal of the one carbon dioxide molecule, that form the phenylacetate, or another is in the case of phenyllactate will be formed. So the elevated phenylalanine levels in the tissues and then the plasma and urine that is degraded into the phenyllactate or phenylacetate or phenylpyruvate. So this leads to the three kind of serious issues. One is the central nervous system symptoms such as the mental retardation, hyperactivity, jerky movements, failure to walk or talk, delayed social skills, intellectual disability, tremor, athetosis, and then sheaths and etc. Because this phenylalanine is really important for the production of the melanin enzyme because the dopamine, and everything will be involved in the melanin formation. So that leads to the deficiency of the melanin. So that finally results in fair hair, blue eyes, and then the albinism. And then their urine and then this breath will have the mouse and then the musty odor due to the presence of this phenyllactate, phenyl acetate, and then the phenylpyruvate. And as we know that this hereditary of phenylketonuria is the autosomal recessive disorder. So if a carrier dad and then the carrier mother is there, only one out of the four children will have this kind of disease. So because this is autosomal recessive disorder. So usually the carrier does not have any kind of symptoms of phenylketonuria. So the diagnosis of phenylketonuria involves usually we do the prenatal diagnosis is done by detecting the gene mutation in the fetus, and DNA auto diagnosis also will be done after birth. Infants is done by the measuring the blood phenylalanine levels. Usually the normal levels of phenylalanine in the body is 1 mg per TL, but whereas in case of the phenylketonuria, the levels may go up to 6 to 80 mg per DL. Usually, the phenylketonuria is defined in the case of more than 30 mg per DL of phenylketonuria in the blood. The screening test usually done by two ways. One is the plasma or the serum will be sent for the mass spec. That is the tandem mass spectrometry to see whether how much phenylketonuria, phenylalanine is there in the sample. Second is The second test is GU3 test. So this GU3 test, what it will do, this usually based on this principle of the bacterial growth. So so there are certain bacteria which can grow only the phenylalanine is given in the Petri plate. So while we are making the media, we'll make two set of plates. One is in the presence of phenylalanine, and the another one is in the absence of phenylalanine, and third one is with the patient samples. So we will get to know whether this bacteria street or it grows on the plate where the patient sample is there, because due to the high levels of the phenylalanine, the bacteria can grow. Whereas when the phenylalanine is not given enough, then the bacteria will not be grown in the bacterial growth. We cannot see it in the plate of agar. So this is one such example. If you see the positive control here, the increasing concentration of phenylalanine and then the bacterial growth we can see, whereas other negative controls didn't show any kind of bacterial growth. Whereas only one set of the ring that we can see here, that bacterial growth, which means that this patient has phenylketonuria. And there is other set of tests will be done using the urine ferric chloride test, where we take few drops of the fresh urine sample and it is dissolved in the solution of water, ethanol, and few drops of the freshly prepared ferric chloride. So, due to the presence of this phenyl pyruvate, this forms an intense blue-green color because of the, it makes a complex with the ferric chloride and indicating the presence of the phenyl pyruvate. That is a positive test. So, it can be green to blue color thing. Whereas the negative test will show the yellowish brown color of ferric chloride. So this is the two negative results, and these two are positive test results. And we have already seen this phenylalanine is a ketogenic, so it can also produce phenylpyruvate, which is a ketone body actually. So in urine, that gives the positive results for the Rutras test, because Rutras test is usually used for the ketone bodies. And the precautions, if you see, when in the case of phenylketonuria, the individuals with this PKU must be allowed for the food sweetened with aspartame, that is especially the artificial sweetener that made from the amino acids phenylalanine and then the aspartic acid. And it is recommended that women with PKU who are childbearing age closely adhere to the low phenylalanine diet, because that leads to the risk of miscarriage, mental retardation, and microcephaly, and then congenital heart disease in the child is high if the mother's blood phenylalanine is poorly controlled. And the treatment, if you see, so far there is no cure for phenylalanine, phenylketonuria. Usually that leads to, we will reduce the symptoms or the severity of the disease usually through the diet. So a strictly controlled phenylalanine free diet up to the age of 14 years must be carried out, and then the permanent monitoring of blood phenylalanine levels. After 14 years of age, the growth and development of the brain is not affected by the high levels of the phenylalanine. So phenylalanine itself is an essential amino acid. Small dose must be supplied. An insufficient phenylalanine intake may cause the mental and then the physical sluggishness, loss of appetite, anemia, and rashes and diarrhea. The next amino acid that we are going to see is tyrosine, and tyrosine is a hydroxylated form of phenylalanine. So only one extra OH group will be there in the case of tyrosine when compared with phenylalanine. And as we already know, tyrosine is also an aromatic amino acid, but it is a non-essential amino acid because it can be produced or it can be derived from the phenylalanine in the body. So the degradation of the tyrosine occurs mostly in the liver, and the degraded end products can form fumarate. That's why it's called glucogenic, and whereas acetoacetate can be used for as a ketogenic amino acid. And the predominant phenylalanine metabolism occurs through tyrosine. And usually, as we already seen, this can synthesize the epinephrine or norepinephrine, dopamine, thyroid hormones, and the pigment melanin as well. And we have seen this first set of reaction where this phenylalanine can be converted to the tyrosine in the presence of phenylalanine hydroxylase as well as the tetrahydrobiopterin. We are going to see the other set of reaction, how this phenylalanine or tyrosine can be converted to acetoacetyl CoA or fumarate in the reaction. The first reaction that we are going to see, transamination reaction, where this tyrosine will be converted to para-hydroxyphenylpyruvate. So here the enzyme tyrosine aminotransferase helps. So it will convert the alpha ketoglutarate to the glutamate, because the transamination reaction, one amino group will be removed here, and all transamination reaction in the happens in the presence of PLP. So this is also a pyridoxal phosphate dependent reaction, and it usually induced by the glucocorticoids. And second is homogeneous production. So what will happen in this case? This para-hydroxyphenylpyruvate, in by the presence of para-hydroxyphenylpyruvate dioxygenase or para-hydroxyphenylpyruvate oxidase, which is a copper-containing enzyme, that will convert the phenylpyruvate to homogentisate. So here, one molecular oxygen will be converted to carbon dioxide. So one carbon molecule will be removed. And next step, we will cleave the aromatic ring of homogentisate. And what will happen here, that homogentisate 1 comma 2 dioxygenase will do one molecular oxygen will be incorporated in the system, and one H plus ion will be removed. So again, mallyl acetoacetate will be formed here from the homogentisate, and again the isomerization reaction will take place, where mallyl acetoacetate will be converted to fumarate acetoacetate. From the isomerization reaction, finally hydrolysis will take place by the in the presence of 3 keto acyl CoA, from the fumarate acetoacetate, that the fumarate acetoacetate by the presence of H2O, that will be converted to fumarate and then the acetoacetate. This acetoacetate in the presence of the 3 keto acyl CoA transferase, in the presence of succinyl CoA, that will be converted to succinate, then the acetoacetal CoA will be formed. That's why hence the phenylalanine and tyrosine are partially glucogenic and then the partially ketogenic, because both precursors for the ketone bodies and then as well as the glucose can be synthesized or can be derived from their catabolism. So if you see the disorders of the tyrosine metabolism, there are three set of tyrosinemia, and then finally we'll see the alkaptonuria. First, tyrosinemia is the last station that we were talking about, that is fumarate acetoacetate. If that is deficient, then the tyrosinemia will take place. That causes the liver failure, rickets, renal tubular dysfunction, and the polyneuropathy. And tyrosine and then its metabolites are excreted in the urine usually, and it can happen both in the case of acute as well as in the chronic manifestation. Acute in that case, hepatic and then the renal failure leading to death within a year. In the case of chronic, diarrhea will happen, vomiting, cabbage-like odor due to the production of the organic acid, and vitamin D resistant rickets can happen in this case. And overall, this fumarate acetoacetate is accumulated in the body due to the unavailability of this fumarate acetoacetate. So that leads to form the reduced form called succinyl acetoacetate, and this decarboxylation of the succinyl acetoacetate forms succinyl lactone, and this succinyl lactone leads to inhibition of this heme synthesis pathway. So the succinyl lactone goes and binds to the ALA dehydratase, where it inhibits the delta aminolevulinic acid process in the heme synthesis pathway. So that is also leads to the heme low level in the case of tyrosinemia type 1. And this can be diagnosed by several ways. First one is we can see the succinyl lactone levels in the serum and in the blood as well. And tyrosine levels are normal or slightly elevated in the body. And methionine levels are so high, and then delta aminolevulinic acid is high, whereas the alpha fetoprotein that is very high, which is a marker of hepatocellular carcinoma. And second is the tyrosinemia type 2, which is also known as the oculocutaneous tyrosinemia, and it is otherwise called as the Richner-Hanhart syndrome. What happened here? This enzyme, tyrosine aminotransferase, the previous enzyme where this tyrosine will be converted to the para-hydroxyphenylpyruvate, that will be deficient. So this leads to the blockage in the routine degradative pathway of thyrosin, and this characterized by the skin hyperkeratosis of palm and then eye lesions, and as well as the neurological problems. And this is the tyrosinemia because it both happens in the other skin area as well as in the ocular region. And third one is tyrosinemia type 3 that happens due to the absence of para-hydroxyphenylpyruvate dioxinase, where this para-hydroxyphenylpyruvate cannot be converted to the homogentisate. So that mostly temporary, and then if you give the ascorbic acid in the case, that reacts to the ascorbic acid. And the substrate inhibition of this enzyme is overcome by the presence of ascorbic acid. And finally, alkaptonuria, which is first described in 1649 by Lusitanus, and it is also an autosomal recessive disorder with occurrence of 1 in 25,000 births. And the enzyme defect in this thing is homogentisate oxidase. And then homogentisate accumulates in the tissues and blood, and it's excreted in the urine. And due to the presence of more homogentisate in the body, that gets oxidized to the corresponding quinones, and which polymerize to give the black or brown color usually. That's why the phenyl, this alkaptonuria patients have urine results the coke in color. That is in the common representation that you can see it here. And usually we do the chromatography for the quantification of the homogentisate in the urine itself. So if you see this homogentisate usually convert to the mallyl acetoacetate and the femoral acetoacetate. But due to the absence of this homogentisate 1,2 dioxygenase, that converted to the that benzoquinate acetate, and then finally oxidation and then free radicals that binding to the tissue. That is also happening. And the clinical manifestation, if you see overall, that homogentisate gets oxidized with the polyphenol oxidase and to benzoquinone and acetate, which undergoes a polymerization to produce pigment called alkaptone bodies, and which deposits occurs in the connective tissues, bones, and various organs, nose, ear, resulting in the condition known as the ocrosis. And arthritis is also seen in the case of the pigment deposition in the joints, as well as the treatment by the consumption of the protein diet with relatively low levels of phenylalanine content. Another metabolic roles of tyrosine, if you see, it can be useful in the case of the synthesis of the catecholamine, in the case of the epinephrine, norepinephrine, dopamine, and synthesis of the thyroid hormones such as the T4, thyroxine, and trihydrothioneine. And synthesis of melanin pigment also takes place by the action of like in the presence of tyrosine. So if you see, first we will see about the we'll see what catecholamine synthesis that will be synthesized usually by from the tyrosine amino acid. This happens in the adrenal medulla, especially in the sympathetic ganglia. So what happens? This tyrosine is taken up actively by cells of the adrenal medulla, pheochromocytes, and the neuroglial cells. This tyrosine will be converted to dopa, that is dihydroxyphenylalanine first. Then the conversion of dopa to dopamine, and then the dopamine to the norepinephrine, and then the norepinephrine to the epinephrine will happen. First, what happened? This in the cells of pheochromocytes and then the neuroglia cells in the mitochondrion, this tyrosine will be converted to DOPA, that is dihydroxyphenylalanine. That happens in the presence of tyrosine hydroxylase. And this is really, really an important step in the tyrosine metabolism or in the catecholamine synthesis. So this requires the tetrahydrobiopterin as well as the molecular oxygen and then the NADPH. Then this conversion of dopa to dopamine, how it happens? That happens in the cytosol. So once the dopa synthesis from the mitochondria, it will come back to the cytosol, where the dopa decarboxylase will be there. So this dopa decarboxylase, by in the presence of PLP, that remove the one molecule of carbon dioxide that's formed dopamine. So usually in the case of the Parkinson's disease, the dopamine content in brain is reduced. That's why this is really, really important neurotransmitter in the body. If this is not there, then that leads to the Parkinson's disease in most of the cases. And if you see alpha methyl dopa will inhibit the dopa decarboxylase that prevent the production of epinephrine. So it is an antihypertensive drug. And next, this dopamine, in the presence of dopamine hydroxylase and then vitamin C and then the copper, that will be converted to norepinephrine. And here, dopamine is getting hydroxylated to norepinephrine by the enzyme. And this enzyme is copper containing enzyme. And vitamin C is required for the reaction. So usually in the dopamine from the cytosol enters the chromaffin granules of the pheochromocytes or granulated vesicles of the brain cells of nerve endings. There only this kind of reaction takes place. And in the norepinephrine, by the action of methyl transferase, from the acetinosyl methionine, the methyl group will be transferred to the norepinephrine. There it will form the epinephrine. And usually this reaction does not take place in the nerve cells where the synthesis stops at the norepinephrine stage itself in the nerve cells. And epinephrine after synthesis in the cytosol moves back to the chromaffin kinase where it is stored. And if you see the actions of epinephrine, it increases the blood pressure and then increases the rate and force of the myocardial contraction and relaxation of the smooth muscle of bronchi and antagonize the insulin formation and increases the glycogenolysis and stimulates the lipolysis. And adrenaline is released from the adrenal medulla in response to flight, fight, and then the exercise and hypoglycemia states. And we have seen the so far synthesis of the dopamine or sorry, epinephrine. Now we are going to see how degradation happens. The norepinephrine, in the presence of the N-methyl transferase, this SAM will be converted and the epinephrine will be formed. This epinephrine, in the presence of catechol O-methyl transferase, that form the metanephrine. And this metanephrine, again, in the presence of the monoamine oxidase, MAO, it will be formed vinyl mandelic acid. So this vinyl mandelic acid usually excreted in the urine, that is 2 to 6 mg per 24 hours. And this VMA is increased in the pheochromocytoma as well as in the neuroblastoma conditions. And the first disease in this case that we see it as a Parkinson's disease. This is due to the degeneration of the dopaminergic neurons, substantia nigra in brain, and this leads to the decrease in the dopamine production in the body. And this dopamine is involved in the imitation of the voluntary movements and then avoid response reflexes. It is also produced by the hypothalamus where it inhibits the prolactin synthesis. And what will happen due to the Parkinson's disease? The slowness of movements will cease because which is called as hypokinesia, and then the rigidity of muscles, repeated involuntary movements called tremors, and patients often have the expressionless face, decreased eye blinking, and the flexion of head and stooping postures, etc. And sleep disturbance and changes in mood and behavior due to the depression and dementia, and debilitating condition also seen in the body. Usually, in the case of Parkinson's disease, the dopamine replacement is the principle of therapy. Dopa is given as a treatment, and dopamine because it cannot enter the blood cells. And lower levodopa and carbidopa is commonly used, and MOA inhibitors, that is selegiline, and then the COMT inhibitors, that is entacapone, are also used in the augment the effect of the levodopa or carbidopa. And sometimes people have seen the drug-induced Parkinsonism also. There is anti-emetic, that is metoclopramide, and then lithium carbonate used in the manic depressive psychosis. Antihypertensives like Rasparin, and then the methyl dopa also used. And the next disease is pheochromocytoma that usually seen in the case of the tumor of adrenal medulla that leads to the excessive catecholamine synthesis, for example, epinephrine and then the norepinephrine, and that leads to the severe hypertension and then hot flushes and excessive sweating and then the diarrhea. This usually the diagnosis made in the case of the urinary valine mandelic acid, that is VMA estimation. Normal urine usually contains the 2 to 6 mg per 24 hours excretion, whereas in the case of this tumor, more VMA will be secreted. And this treatment usually involves a surgical removal of tumors. And next is thyroid hormone synthesis. Thyroid hormone usually two things. One is T4 and then the T3, thyroxine, otherwise called T4, and triiodothyronine, otherwise called as T3. From the tyrosine residues of the protein thyroglobulin, which is a large precursor molecule and which is activated iodine. This thyroglobulin, if you see, which is iodinated largely and glycosylated protein of 660 kilodalton. And the carbohydrate content is 8 to 10%, whereas iodide content is 0.2 to 1%. Two large subunits will be there. That 115 tyrosine residues are there in the molecule, and each of which is a potential site of iodinization. In this thyroglobulin, About 70% of the iodide in the thyroglobulin exists in the inactive precursors, that is called monoiodide iodothyrosin, that is MIT. Another one is the dihydrothyrosin, that is DIT. Well, 30% is in the active form, that is called T4, and then the T3. Majorly, T3 is the active form of thyroid hormone, and it's usually stored in the intracellular reservoir called colloid. And this is the synthesis of the thyroid hormone, where the tyrosine amino acid in the presence of the molecular or the activated iodine that will be converted to the monoiodothyrosin, that is MIT. Then again in the presence of again one molecule of iodine that will be converted to dihydrothyrosin. And again one molecule of monoiodothyrosin and dihydrothyrosin forms T3, and then the two molecules of dihydrothyrosin forms T4. And usually this iodine uptake in the cells based on the two mechanism, that is sodium potassium ATP is dependent thyroidal iodine transporter. What will happen, this transporter will take up the iodine from the outside of the cell, such as the extracellular space, and that add the iodine group into tyrosine molecules. And once it gets into the cell, through the sodium potassium ATP is pumped, the concentration of iodide will be more in the cells, and again it will go to the follicular space with colloid to iodinate the thyroglobulin. So this will travel through the thyroid cell, then it will go into the to the follicular space, and in the presence of the peroxidase that will be activated, that is I plus form will be there, where it will get iodinated through on the thyroglobulin in this case. So iodination will happen, that will form the large amounts of D80 and then the MIT, and small amounts of T3 and then the 3,4. And whenever TSH is secreted from the TSH signal is there in the body, so that will leads to the degradation of or phagocytosis of this thyroglobulin protein, where this thyroglobulin will be phagocytosis and then the outer spinocytosis, and by the action of lysozymes, this protein molecule will be degraded, and the secondary lysosome will form, and then the hydrolysis will happen. Due to the hydrolysis, T3, T4 will be released in the case. Whatever the formed MAT, DAT is there, then that again will go for the deiodinase, other then tyrosine molecule will be formed, then that will again go for iodinization. So this is what overall thing. The tyrosine residues of the thyroglobulin form two things, and it can be iodinated on thyroglobulin molecule. Then whenever the TSH is there, then the thyroglobulin will go for degradation. Then the degraded thyroglobulin will produce T3 and then the T4, and then unused MAT and then the DAT will go for usage of tyrosine again. So the stimulation by TSH, phagolysis activity that activates the acid protease and then peptidase hydrolyze the thyroglobulin into its constituent amino acid, including T4 and then the T3, which is discharged into the extracellular space. And the deiodinase removes the iodine from the inactive mono and then diiodothyronine molecule in the thyroid, and peripheral deiodinase in target tissues such as the pituitary, kidney, and then the liver selectively removes the iodine from the fifth position as well as to make T3, which is the active form. So if you see T3 and then T4, that is involved in the multiple reactions in the body. In terms of the liver, it regulates the lipid homeostasis and influences the susceptibility to the obesity and then the liver steatosis. And then the pancreas, it directs the pancreas development and the function. And then in brain, in hypothalamus, it regulates the feeding behavior as well as the control the energy expenditure. And for example, in the case of skeletal matter, it determines the shift from the type 1 to type 2 fibers that involves in the regeneration process and increases the energy expenditure. And in the body, it regulates the adipose proliferation and then the Differentiation regulates the thermogenesis and then the UCP1 levels. And in the case of the adipocyte, it regulates the adipocyte proliferation as well as in the differentiation. And the disorders of the thyroid hormone, it can be two. One is the hypothyroidism as well as the hyperthyroidism. Hypo and then hyper are both totally different phenomena. Whenever the hypothyroidism is there, the weight gain will happen, loss of appetite, cold sensitivity, thinning hair, dry skin, constipation, pain, stiffness, swelling in joints, depression, impaired memory, and slow heart rate will see. The hypothyroidism is totally opposite of this thing. If it is weight gain is there, weight loss will be there. Increased appetite I've seen, and the heat sensitivity is there, and fine and brittle hair, thinning skin, and frequent bowel movements will be there because of the that only weight loss will happen, and tremor will happen, nervousness, anxiety, or irritability, rapid heart rate will be there. That is called tachycardia, and palpitation will be there. There are some common symptoms, that is fatigue, muscle weakness, and menstrual irregularity, and enlarged thyroid gland also. People have seen in the case of goiter. And next compound synthesis from the tyrosine, that is called melanin. So melanin is a pigment and which gives a black color to the skin, hair, and the eye. The synthesis of the melanin occurs in the melanosomes present in the melanocytes, the pigment producing cells. The tyrosine, the precursor for melanin, and only one enzyme, namely tyrosinase, a copper-containing oxygenase, is involved in this formation. There are two set of melanin out there, eumelanin as well as the pheomelanin. Eumelanin is the black and brown, which, that is responsible for the black and brown color, and that is insoluble in the in body and heterogeneous. The reason it's heterogeneous, it is involved of cross linking of two molecule. One is 5,6 dihydroxyindole DHA, another is 5,6 dihydroxyindole 2 carboxylic acid, that is DHICA polymers, and which is a high molecular weight compound. Next one is a pheomelanin, which produces the yellow to reddish brown color, and this is soluble and then the sulfur containing uh, melanin compound, and which is a oligomery structure incorporates the benzothiazine and then the benzothiazine. Another melanin called trichochromes, that is low molecular weight compounds, contains the sulfur, which are related to the pheomelanin. And another compound is called neuromelanin, which is the dark, response of dark color, insoluble pigment produced by the dopaminergic and then the noradrenergic cells of the substantia nigra, and locus as a breakdown product of dopamine. The melanin synthesis, usually if you see the tyrosine, which is an amino acid, is non-essential amino acid, by the action of thyroxine is converted to L-dopa. This L-dopa, again by the action of thyroxinase, convert the L-dopa quinone. If the cysteine is there, then it will go for the cysteine glutathione will be there. Then cysteine L-dopa will be formed. The cysteine L-dopa finally it forms the pheomelanin. Whereas the cysteine levels are not there, then it will form the eumelanin in this case. So this is the two different mechanism people have seen how this tyrosine will be converted to pheomelanin when the cysteine levels are so high, and the cysteine is not there, then it will be converted to eumelanin. And this melanogenesis is usually produced in the multi-stage chemical process known as melanogenesis, where the oxidation of the amino acid tyrosine is followed by the polymerization. And pheomelanin that we have already seen, which is a cysteine derivative produced when melanocytes are malfunctioning due to the derivation of the gene to its recessive format. Usually, the melanogenesis is stimulated by the UV radiation, which upregulates the production of the pre-opiomelanocortin, that is POMC, and its downstream products, alpha melanocyte stimulating hormone, that is alpha MSH, and then the adrenocorticotropic hormone. There are disorders in the normal case also not even disorder. The moles are usually formed with the hyperpigmentation due to the hyperactivity of the melanocytes and the leukoderma, whereas the localized absence of the degeneration of the melanocytes, absence of tyrosinase in epidermis results in the white patches on the skin. And albinism also is an inborn error of metabolism, which is generalized lack of the melanin synthesis, and graying of hair people have seen, disappearance of the melanocytes from the hair root. The copper deficiency leads to tyrosinase is really, really important enzyme for this melanin synthesis. So when the copper deficiency is there, there will be the disturbance in the pigmentation during copper deficiency. Hair synthesis at the time of deficiency may be depigmented. If the copper deficiency is intermittent, then alternate black and white regions may be seen. in the hair that is called flag type of hair. And then the another one is called malignant melanoma, where the melanoblast proliferation takes place so high. One such disease that we are going to see today, there is albinism, which is called albino means white in meaning. So this is also inborn error of metabolism due to the lack of synthesis of the melanin pigment, and which defects in the tyrosinase enzyme synthesis. And this is also the autosomal recessive disorder, which has 1 in 20,000 incident. The biochemical basis, if you see, there is deficiency or lack of the enzyme thyroxinase, and then the decrease in the melanosomes of melanocytes, and impairment in the melanin polymerization, limitation of the substrate, which is the tyrosine availability, and lack of the protein matrix in melanosomes. There are two types of albinism. One is the oculocutaneous albinism. It happens both in the case of eye as well as in the skin. Second one is the ocular albinism, which affects only eye, not the skin. So this oculocutaneous albinism, they can be differentiated by clinical presentation, the biochemical and other features. Such albinos can be biochemical of two types. One is the tyrosinase negative albinos as well as the tyrosinase positive albinos. This ocular albinism can happen in the case of both autosomal recessive as well as an X-linked trait. So it can happen in the both the ways. So this is the example. If you see, they will have oculocutaneous albinism. This is only the ocular albinism example. And whenever the melanin pigment is not there, which the skin is sensitive to the UV rays, and that leads to the damage of the your DNA and the genetic material. So that finally leads to the skin cancer called malignant melanoma or the cancer of the melanocytes. So these patients, albinism patients, they are photophobic in nature due to the lack of pigment in the eyes. So the final set of topic, that is tryptophan, which is also an aromatic as well as an essential amino acid in the body, and it is not synthesized in the body itself. And the degraded usually degrades to alanine as well as the acetoacetate. So the alanine is glucogenic amino; it leads to the glucogenic pathway as well as whereas acetoacetate leads to the ketogenic form pathway. The precursors synthesized by this tryptophan are serotonin, which is a neurotransmitter, niacin, that is vitamin, as well as the melatonin. Melatonin is an hormone, not melanin. That is different. This is different that you have to see. So the catabolism of tryptophan, if you see from the tryptophan, that will be converted to N-formyl kynurenine by the presence of pyrrolase. Again, the N-formyl kynurenine will be converted to the kynurenine by the action of formylase. And again, the kynurenine will be converted to 3-hydroxykynurenine. Then the 3-hydroxykynurenine will leave the alanine here, and then the 3 hydroxy anthralenate will be synthesized. Then the ring opening will happen here by the presence of one oxidase. Then after the ring opens happen, then 3 acryl 3 amino fumarate will be formed. Then again the decarboxylase reaction, and finally it forms acetoacetate. So that's why here one alanine will be reduced, that goes to the gluconeogenesis, and the second acetoacetate will go for the ketone body synthesis. That's why these are called both ketogenic as well as the glucogenic pathway. And more than 95% of the tryptophan is mainly metabolized to kynurenine and indolamine 2,3 dioxinase in the immune system and the brain, and tryptophan 2,3 dioxinase in the liver are responsible for the synthesis of kynurenine from the tryptophan. And any kind of issue happens that leads to the cognitive defects in the schizophrenia are associated with the imbalance in the kynurenine degrading enzymes. This reduced levels of kynurenine in bipolar disorders, and kynurenine production is increased in Alzheimer's disease and cardiovascular disease as well. And kynurenine is associated with the movement disorders. So usually in the case of the metabolic role of tryptophan, it is really involved in the production of NAD plus as well as the NADP plus compounds, and it is also involved in the serotonin synthesis, which is a neurotransmitter, and finally, it is also involved in the melatonin, which is a hormone. So if you see which of the following is a byproduct of the ketogenic amino acid, not alanine. Alanine is involved in glucogenic. Ascorbic acid is a coenzyme, which is otherwise called as vitamin C, and then succinyl CoA is it's an intermittent of TCA cycle. So the leftover thing is acetoacetyl CoA. So option C is the correct answer. So acetoacetyl CoA. Active form of thyroid hormone is DAT, which is Thyronin, which is not, and monoiodothyronin is also not. And the T3 is the correct option because thyroid hormone is T3 and T4, so T3 is the active form. And TSH is not synthesized from thyroid, which is synthesized from the pituitary. And choose the correct pair or pairs. So melanin is synthesized from tyrosine. Yeah, that is correct. And melatonin is also synthesized from tryptophan. That is also correct. Dopa is synthesized from tyrosine. Yeah, correct. And tyrosine is synthesized from phenylalanine. So all pairs are correct. So I think this is what I have for the day. And if you have any doubt, we can go back and then check it. Do you have any doubt, Dr. Sonika? Hello. Dr. Sonika, do you have any doubt?
No, sir, I don't have any doubt.
Yeah, so shall we wind up then?
Yes, sir.
Yeah,
Thank you, sir.
yeah, thanks. You can be.